And just to remind everyone, we are recording this webinar, so it will be available for on-demand viewing in a couple weeks. But I wanted to introduce now Sarah Reising. She has been a practicing speech language pathologist for 10 years. She completed her undergraduate degree at Western Kentucky University and received her master's degree from Florida State University. For the past 5 years, she has worked at the Mayo Clinic in Jacksonville, Florida. She is an instructor in speech pathology in the College of Medicine at Mayo and has worked as the lead SLP in both the ALS clinic and the Augmentative and Alternative Communication Clinic. So Sarah, thank you for being here. I will turn it over to you.
So also during my day-to-day work, I am in the acute care hospital on the neuro floors, neuro ICUs, general medical floors, and ICUs, as well as in the outpatient clinic. During my prior positions, I've worked in subacute rehab and home health. So this has given me exposure to a variety of neurological diagnoses, and my experience has primarily been with adults, but I've covered a variety of settings. So I'm hoping that I can give you guys an interesting perspective today. So my financial disclosures, I am an employee of Mayo Clinic and I'm receiving an honorarium from the MDA today. And just a disclaimer, the presentation is for educational purposes today. And I'm going to show some pictures. So if anything, specific brands are used, it's not necessarily an endorsement, but just to show you as an example. My objectives in talking today are to help you all understand the domains that an SLP evaluates and treats, to understand the general services we provide as a speech-language pathologist, and to identify when to consult with an SLP and how you can obtain those SLP services. So what is a speech-language pathologist? A speech-language pathologist is defined as the professional who engages in professional practice in the areas of communication and swallowing across the lifespan. So this can consist of screening, which is kind of briefly looking at these areas to see if further evaluation is needed, formal evaluation, so really kind of digging deep into these different domains to see if there are areas that need to be addressed, and then treating, so addressing those areas where we find there may be some room for growth. We also are, as SLPs, advocates for our patients, advocates for our profession. We participate in outreach. So outreach, could be in the state level, funding, or and governmental level, advocating for people with disabilities. Also research, so working with different organizations to look at improving the way that we're treating these areas, treating different neurological diseases or whatever the disease may be. We work collaboratively with other professionals, so depending on the setting, it may be working with physicians and physical therapists, occupational therapists, nurse practitioners. It may be in a school setting working with classroom teachers or ESE teachers. We also work on educating, so just getting out there, letting people know, as patients or as family members what we do, or educating different professionals on our role and how we can help with their patients or clients. And then counseling, so helping support people who have these different areas of deficit that we are working to improve. What areas are addressed by an SLP? So I tried to choose areas that might be covered within the neurological realm. So there are other kind of things that maybe I'm not going to touch on today, but these are more the areas that we may see patients with a neurological disease that we can help with. So those domains are swallowing, speech, language, communication in a patient with a tracheostomy, augmentative and alternative communication, and cognitive linguistic skills. And so we're going to dive a little deeper into each of those today. First, we'll start off with swallowing. So dysphagia is the medical diagnosis term for a person or for the difficulty with swallowing. So we call it dysphagia. As an SLP, the areas that we assess are the different components of swallowing. are the oral phase, so everything that has to do with while the food is in the mouth. So from bringing it from, the cup or the spoon into the mouth, whether it's sucking it up or getting enough, retrieving enough the spoon, kind of manipulating and controlling it in the mouth, forming it into a ball or chewing it up, and then propelling it from the front of the mouth to the back of the mouth and into the throat. The pharyngeal phase, which is the throat part of the swallow. So kind of the motor process that has to happen to get the airway out of the way and allow that food to pass over the top of the airway and into the esophagus. So that's the pharyngeal phase of the swallow. The esophageal phase of the swallow, so from the point where it leaves the throat and enters into the esophagus. This is something that, as a speech pathologist, we don't necessarily diagnose or treat, but it's something that in the realm that when we're evaluating, it's something that we might pick up on, that there is an area that needs further investigation in as far as the esophageal component. And that would be something we would defer to our colleagues in GI or ENT to take a further look at, but it might be something that an SLP would talk with you about. And then there's also atypical eating. So that would consist of, food aversions or not being able to tolerate or eat different consistencies of food. So as a patient or a caregiver, what do I look for that would be an indicator of trouble with swallowing? So that might be in the oral phase, spilling from the mouth, whether it's the food spilling or the liquid spilling, the food or liquid staying behind in the mouth after we swallow, pocketing of that food in the cheeks, difficulty with chewing or recollecting that food and transiting it back into the throat. Those would all be signs, oh, something is off with my swallow. I might want to check in with an SLP. When we talk about the pharyngeal phase or the throat part of the swallow, if there's coughing, if there's choking, if there's changes to the voice quality, so wet quality or like a gurgling quality when we're swallowing, if the food is sticking in the throat or taking more swallows than normal to clear through the throat phase of the swallow, all those would be signs something might be changing or further investigation might be warranted. Signs of esophageal changes or esophageal dysphagia could be belching, food sticking, feeling that food sticking below the level of the throat, so feeling that food kind of at the chest level. And then signs of reflux, so heartburn sensation or food kind of coming back up. And then atypical eating would be that food sensitivity again, food refusal, difficulty with tolerating different consistencies in the mouth. So if a person has dysphagia, what's going to happen next? So if you present to the speech pathologist, the first thing that we do is an evaluation. So there's a couple of different types of evaluation for dysphagia. There are clinical or bedside evaluations, and those are going to be done, in an office setting or in a hospital room. The speech pathologist will interview, assess oral movements, see how things are moving as far as your mouth goes, may give you some different consistencies of food or have you drink different liquids, and kind of assess those phases that we talked about earlier. Depending on what the difficulty is, we may refer for an instrumental swallow evaluation, and those are also completed with the speech pathologist. There's two different types of instrumental swallow evaluations. The first type is a modified barium swallow study. It's also called a video fluoroscopic swallow study, MBS or a VFSS. That test is done in radiology with a radiologist present. The patient drinks different consistencies of barium, and the SLP assesses how they're moving from the mouth through the throat and into the upper part of the esophagus and beyond. It looks for where the deficits are during those different phases of the swallow, and it gives us information on how we're going to treat those deficits. The other type of instrumental swallow evaluation is a fiber optic endoscopic evaluation of swallowing, or a FEES assessment. This is done in an office setting usually with an endoscope. So with a scope that's passed through the nose into the upper part of the throat, and the SLP then feeds you different consistencies of foods and liquids and watches them go down and to see, again, where are those areas of deficits, where are things, the issues occurring that we need to address in therapy. So the next phase for dysphagia would be treatment. After we have those evaluation results, we've identified those areas, then the SLP works with the patient to determine what are our goals? What do we want to achieve with therapy? What does the patient want? What does the family want? What does the SLP think that is, the most important thing for keeping the person safe, keeping things from entering the airway, or keeping the patient from getting malnourished because of limited endurance? Those goals are established, and then we work towards those goals during treatment. The treatment could include exercises, so exercises targeting those muscles of the mouth, exercises targeting the muscles of the throat, exercises targeting breathing. There's a close correlation between breathing and swallowing. They both occur in the same area, so if we can't coordinate them, or if the breathing is impacting swallowing, we might address it that way. In therapy, we might also address compensatory strategies. Are there changes that we can make that will make the patient more safe, or more efficient with eating, by changing the way that we're doing something? May also be modifying those textures. So thinking about the types of foods that we're eating. Are they hard? Are they soft? Are they blended, to make things more safe or more efficient? It may consist of modifying the liquid viscosities, so thinking about different consistencies of liquid than liquid water versus a smoothie or something like that. And then finally, counseling and education. So going over what the recommendations are, how that's going to impact, everyday life. Eating is a very social task, so we do it often with our family or with our friends. And if someone is experiencing dysphagia, that can impact that social aspect of life. And so helping to provide some guidance and some counseling with how to deal with these changes, and kind of make those modifications and integrate them into into the person's life successfully. The next area that I wanted to touch on is language. So you may see an SLP if there's changes to language function. So the components of language, kind of broken down, different aspects of language, are phonology, or how the speech sounds are arranged; morphology, the forms of the words; syntax, so the arrangement of the words or the phrases within the language; semantics, the meaning of the words; pragmatics, that social aspect of language; pre-linguistic skills, so thinking about turn taking and eye contact; paralinguistic skills, so thinking about gestures, signs, body language; literacy, which consists of reading and writing. So all of those kind of components of language might be addressed or assessed by an SLP. As a patient or a caregiver, what do I look out for that would indicate a change in my language function? So I will preface this with, it's going to depend on your age, as most things do. If it's more of a pediatric population, we're looking at those milestones. Are we hitting our developmental milestones? Are we following that typical trajectory of developmental language? Looking at social interactions, are those interactions occurring with peers appropriately? Is the person able to effectively express their thoughts and emotions? So if there's a breakdown with effectively expressing those thoughts or emotion, frustrations occurring because we don't have that ability to put together the words to express what we're thinking or feeling. Difficulty finding the correct word. So that could be something that kind of a change that we notice later in life. If we're going for a word and we're not able to retrieve that word like we once were, or if we're going to retrieve a word and we retrieve the wrong word. So that change in ability to access words. And then if there's any difficulty with understanding or listening, if during conversations the patient or person is no longer able to comprehend what's coming in as easily as they once were, that would also be something that an SLP could work on. And then again, difficulty with reading or writing, again, varying by age. If we're not developing those skills appropriately in the pediatric setting, or if there's a breakdown that's happening once we've been able to read and write for years and years, and now this is suddenly becoming a more challenging task, or I'm not formulating those sentences the way I once was able to. The next aspects that I wanted to hit on were speech production, voice, and resonance. So I kind of group those all together because often we kind of think of these all as one, but they really from an SLP standpoint, we kind of break them out into these different areas. So when we think about speech production, that's how it sounds when it's coming out. So not the words themselves formulating, that would be language, but speech production is getting it out. How do things look from a motor planning standpoint? So when that message is transmitted from the brain to the muscles of the mouth, how is that plan being sent and being executed? That could come out in articulation or phonology. So how those sounds are coming out, are we articulating those sounds accurately, or is there a change in that motor ability? Voice is going to be more of the quality of the voice. So if you think about a hoarse voice or a raspy voice, a breathy voice, so changes in that aspect of how it sounds when it comes out. Also within voice would be loudness. Do I have that ability to project to get my voice loud? Do I have control when I'm in a quiet environment to bring my voice down to a lower level? Resonance is also another area. So that would be, how is it sounding? How is it resonating? How is it coming out? Or is it more coming from my mouth? Is it coming from a combination of my mouth and my nose? Is it more coming from my nose? Just kind of how that sound is resonating within our body. So what to look out for as far as changes in these areas. So again, I'll preface with, it depends on your age. As in the pediatric setting, again, are we following normal developmental milestones with speech sound acquisition? So as we age, we know if we've watched a little kid grow up, some of those sounds are going to be normally mispronounced, and then as they get a little bit older, they start to pronounce them correctly. So there's norms for those, and if we're hitting all of those milestones appropriately, it's not something to be of concern. But if we're not quite getting some of those sounds as we need to, then it might be that it's appropriate to work with an SLP. If there's changes or irregularity in the production of those speech sounds, so a sound that we have developed has changed in the way that we're producing it. We've been able to say the sound, and now suddenly we aren't able to say it that way consistently. And then is there a change in quality? So do we have slurring, hoarseness, breathiness, changes to that voice? Do we have a change in our rate of speech? We're talking too quick or too slow, or not able to control and vary that rate. And then the nasality. Do we find that we're too much in our nose or not enough in our nose, or air is escaping through our nose? All of those would be changes that would warrant coming to visit an SLP to see if there's something we can do to work with. All right, so kind of thinking all of those things, speech, language, voice, and resonance, what would you do once you got to your SLP? The first thing is going to be formal assessment. So formal assessment could consist of a lot of different things. Criterion referenced tests, which are going to be more looking at the person's ability to achieve certain criteria. That gives us the ability to test that criteria today, do some treatment, test it again, and then compare. How do you compare to yourself? Are you meeting that criteria are you improving in your ability to meet that criteria? Norm reference testing. So that type of testing is going to look at how does that person compare to a group of their peers? Are they achieving at that same level, or are there areas where they're not achieving at the level that their peers would be achieving? It could also be a survey, so a series of questions and answering responses from the patient or responses from caregiver, family, parent. Informal testing is also often part of that evaluation process. So that may be language sampling, where we have the person describe a picture, or if it's in a pediatric setting, it's going to be playing with toys and talking about those toys to gather how does that spontaneous speech come out for that person, and interviewing. So talking to, again, parents, family, caregivers, patient, just interviewing them. How are things going with language? What areas are you noticing there's changes? And then the next step would be, once we have those results, once we've identified those areas we want to work on, again, talking with patient and family and using those results from that test, what goals do we want to set? What do we want to try to improve on? In treatment, once we've set those goals, it's probably going to target either developing new skills, rebuilding those abilities that have changed, if we can rebuild them, It may focus on compensatory strategies. So it may be that some of those skills we're not going to be able to get back. And so we need to come up with ways to kind of work around what we're working with now. And again, counseling and educating. I can't stress enough, having changes in the way that we communicate can have a big impact. We're social beings as people. So communication is important. And so sometimes dealing with and processing those changes is something that the SLP can help the patient and their family deal with. Communicating in tracheostomy patients. So the next population that we're going to touch on. So this is a kind of a very niche population and may or may not be pertinent, but this is again somebody who has a surgically placed tracheostomy too. Because of that anatomical change, may need some help with communication. In those assessments, what we would do is again look at the mouth movements. Do we have the strength and ability to articulate? Definitely respiratory function. Those tracheostomy tubes are placed for breathing. So we have to look at, is this person appropriate to start working on communication from a breathing standpoint? Obviously, breathing is going to be the most important thing. So as the person is able to maybe breathe on their own, or it may be tolerating different vent settings, that we would initiate treatment in this way. The first step would be occluding the trach digitally. So to kind of change that airflow to see if we can get airflow up through the vocal cords and start that voice. Then we'll listen to voicing. How does the voice sound? Is it appropriate to kind of proceed and try to use that voice? And then placement of the speaking valve on the tracheostomy hub. That after that initial assessment, then we would work on treating. And it's going to be similar to kind of what we saw with that speech production, because it's a lot of the same features. Can we get that articulation out appropriately? Can we get that nice, clear, strong voicing? Can we get that breath support and volume? And do we have the respiratory endurance? Because again, that tracheostomy is in place because of breathing. So are we able to tolerate that valve? Next area is augmentative and alternative communication. So a lot of words. I'll abbreviate that as AAC when I kind of am talking. So if you hear me throw AAC, that's augmentative and alternative communication, which means communication that is not, if it means supplementing that communication that's not achieved verbally. So for someone who can do some verbal communication or no verbal communication, how can we help that person communicate with another means, or using another means to help support that verbal communication? If you're thinking this might be something that you'd need, these are what to look out for. So our communication needs not being met with verbal communication alone. So is talking and verbalizing not getting the job done? And could verbal communication be improved? So could that, what you are able to do verbally, could that be helped with a little bit of something else? So there's different types of AAC. So we'll dive into that next. The first is unaided. So that's going to be signs, facial expressions, and vocalizations. So some of these things, or all of these things you can do just with your own body. There's no other external aid that is required. So facial expressions, signs, and vocalizations. The next type of AAC is aided low tech. So this is going to be not a lot of technology. So communication boards, alphabet boards, writing tablets or e-writers. So things that you can write on, think like dry erase board or like a boogie board e-writer. And then low tech communication devices. So devices that maybe have one recorded phrase on them or a couple of recorded phrases that the person is able to access. The next type of AAC is going to be aided high-tech communication. So this is going to be speech generating devices, basically. So dynamic display devices, so technology that has a dynamic display, a display that when you touch it or when you access it, it's going to be able to change. The picture on the screen will change and provide different options. These allow for multiple language systems. There's a huge amount of variety of softwares that are out there. so that you can choose what specifically works for the patient to meet their communication needs. It can be in that pre-literacy stage where we're working with pictures or pictures and words, all the way to a literacy stage where someone is able to read and write successfully, and so we don't need to include those pictures or words. And then multiple access method options are available for these speech generating devices. So when we take out that physical component, if I'm not able to touch my screen, am I able to, hit a switch and access? Am I able to move my head to control the access on the device? Am I able to use my eyes to control the access? So kind of activating that device without the use of the hands or without the use of other parts of the body. Taking that kind of physical component out of accessing a communication device. With these dynamic display speech generating devices, we have that option. So this would be an area too where we're working, again, going back to that collaborative, that multidisciplinary team working with different people. We might kind of seek some guidance from our physical therapy or occupational therapy counterparts to access what's going to be the best way to access this device. The next area I wanted to talk about is cognitive linguistic function. So when we're talking cognitive linguistics, that is attention, memory, problem solving, and other executive functions. So attention would be, focusing. Am I able to stay focused on a task? Am I able to shift my attention from one task to the next and back? Memory can be from the short term. Do you remember what I'm talking to you right now about? Do you remember what happened earlier in the day, or what happened a few years ago? And then problem solving, am I able to work through situations? Am I able to kind of strategically plan and organize to come to a solution? And then other executive functions, regulating feelings and emotions and those type of things. What to look out for in this cognitive linguistic area? Again, varies depending on age. Difficulty with completing ADLs, so activities of daily living, or IADLs, so those instrumental activities of daily living. So ADLs are going to be like feeding, grooming, just basic communicating, and then IADLs are going to be those more complex: shopping, cooking, money management, medication management, kind of those higher level executive functioning skills in those. If you're having difficulty, or someone having difficulty with these because of the cognitive aspect of it, not the physical limitation, then that would be kind of something that you may want to seek out SLP support for. Also, if you're having, again, increased forgetfulness, difficulty with finding the words, those would be indicators for an SLP, or difficulty focusing on a task, kind of the attention aspect of it. So when we come to the SLP for cognitive linguistic function, what will happen? Similar to language assessment, it's going to be that formal assessment. Standardized assessments are typically used. So it could be, again, a criterion reference test or a norm reference test. Could be informal assessment, so running through things with the patient and family, interviewing them, finding out where are these breakdowns occurring. We might be discussing daily schedules. We might be discussing planners and organization, calendars. We might be talking about medication management, seeing how those areas are going, to see if there's an area where we need to work and provide some support. In treatment, again, we're going to work with the patient and the family to come up with these goals, addressing those areas we found we need to work on, and then developing new skills, rebuilding those skills we had, or coming up with some compensatory strategies, ways to work around those deficits, and counseling and educating. How and where to see an SLP. So generally speaking, I get my patients through referral from a physician. So that could be the neurologist, it could be the general practitioner, it could be a family or an internal medicine doctor, an ENT, a gastroenterologist. Really, any doctor can refer to an SLP if they've kind of identified an area, those areas that we've kind of talked about today, that needs a little bit of work that an SLP might be able to help with. Following the evaluation, like we've been talking about, that plan of care or treatment plan is going to be generated. Typically, that will be sent after the evaluation back to that doctor to let them know, this is what we're going to be working on. Do you agree with these goals? Is this kind of what you were looking at? And then that can come back to us. Now, that's kind of coming from a medical setting. If we're talking a school setting or an early intervention or a home health, like a home health pediatric, may be a little bit different. But again, coming from my medical background, that's typically how it works for me as a medical doctor, and I are working to get that referral and then making sure our plan of care is agreeable. Now, the variety of settings that you could see in SLP. So thinking pediatrics could be that early intervention. Early intervention could be done in the home. It could be done in an early intervention center or in a preschool. The school setting, there are school-based SLPs. So there's a speech pathologist at most schools. Then kind of transitioning to more adults, it's going to be in a hospital or a rehabilitation center. An outpatient clinic could be adults or peds. Home health services, so that could be, again, adults or pediatric home health services where the SLP comes into the home to provide the services. And then depending on the type of hospice care that's being provided, sometimes hospice care will cover an SLP coming in to do some basic evaluation and maybe a little bit of treatment too, if there's some strategies and counseling and education that the patient could benefit from. All right, these are the references for my talk today. This is my contact information. If anyone, we're gonna do questions next, but if there's any follow-up questions or anything that I can't answer today, if you reach out to me, I would be happy to talk with you or send you in the right direction to somebody who may be able to help you. All right, and I will open it up for questions.
Thank you, Sarah. I was curious. How is it how do you decide, the length of therapy for someone? And is it something that they do when they just come to visit an SLP, or do they practice at home? What does that therapy look like?
That's a great question. So, depending on the diagnosis and what's found during the evaluation, we'll come up with a therapy plan. So, it depends, again, if the patient is acutely ill and recovering from an acute illness, it may be that it is very intensive therapy and it's
Mhm.
going to be 5 days a week, an hour a day that you're working with that SLP. If it's something that's going to be more chronic and more of like in an outpatient setting, it may be that you're coming once or twice a week to see the SLP for an hour or so. And then I would say home exercise programs are a huge part of speech therapy, because we're not going to see changes if we're working on something only a few hours a day. It's going
Okay.
to be something that to see that transition from just while you're sitting here working with me to every day, some home practice is going to be definitely necessary.
Okay. Okay. And then what if someone gets a SLP from a school? Um, and is that therapy communicated then to their doctor, or is that something that you would urge a parent to do, is to make sure that those communications are sent back to one another?
So in the school setting, things are a little bit different, because in order to qualify for SLP services in a school, and this is my understanding of this,
Okay.
not being a school SLP, but
Mhm.
it has to impact um, education in order to qualify in the schools. So it may be that a patient, let's say, has trouble with communicating some sounds, some of those speech sounds, but they're doing fine overall in education and it's not impacting educational function. It
Mhm.
may be that they don't see a speech pathologist in the schools, but they may go through their insurance to an outpatient clinic or something like that. With kids, it can be a little different. I don't know if you're required to have a referral for outpatient speech in a pediatric population.
Okay.
I would assume if you're going through insurance, you're going to need a referral from a physician. That's kind of the funding issue, is where the physician referral comes in, I think, with adults for, compliance with Medicare. They want that referral from a physician.
Mhm.
So with pediatrics, it can be a little different, but definitely in the schools, it has to be limiting their social or limiting their educational
Got it.
abilities for them to
Okay.
get that SLP service.
And you touched on this, but insurance, Are these services generally covered by insurance? Are you aware of anything like that?
Yes. So there is some variability depending on insurance plans. So
Okay.
sometimes with private insurance, you may have X number of SLP visits a year. Some
Okay.
insurances won't cover SLP services. I know I see a lot of obviously Medicare patients in my
Mhm.
setting. So depending again on the Medicare plan, it may be that some of it's covered and some of it's not. There's definitely a lot of fine details with
Sure.
insurance. So I usually encourage my patients to communicate with their insurance company to find out what their limitations are,
Mhm.
and then and communicate with the facility that they're going through if there's any pre-authorization or anything that the facility can do.
Sure. It's very interesting, just with our care centers, we see a lot with PTs and OTs. And for example, our ALS clinic we have a speech language pathologist with us, but it's it's such an it's an area that is really new, I think, to a lot of people because there's not an SLP in every care center that we do have. And so there's a lot of ins and outs and things that you guys do that I just had no idea. So it's such important work. And thank you very much for helping with the care center, and thank you very much for your time today. I don't see any more questions that have come in. So I think that will be it for them today.
All right, great. Thank you so much for asking me to come and give me this opportunity to kind of share what we do, and I hope we can help somebody with this presentation today.
Exactly. I hope so too. Thank you very much, Sarah.
Thank you.
Have a great Saturday.
You too.